Yes, thank you very much for your presentation. And I'm just showing my slides. Thank you also for the invitation to be here with you. Unfortunately, again, once more virtually, but it seems, let's be optimistic. It seems that maybe the next few weeks or months will look better for all of us. So new advancements in CLL, I will take advantage of the recent ASH Congress in Atlanta 2021. I just want to remind you that here that the presentation is supported by Janssen, but all what I'm gonna say is my personal opinion, and these are my disclosure also to show how dynamic is the field of CLL research, and new drugs are continuously coming in the field, and they are improving the way how we manage our patients. And as I said, coming back from ASH, we really got the impression that we are close to that moment in which to decide the treatment for a patient with CLL is becoming somehow difficult. It's not anymore 1, 2 drugs, but we are ready to understand on one side how the disease is in each single patient. So we have to do a genetic stratification. We know since a long time now the predictive value of the immunoglobulin gene status or the p53 status, and that has to be defined in all patients before starting a treatment. And then on the other side, we have also to know very well the patient himself or herself, and because of the comorbidities, the age, the fitness of each patient. And then we have to combine this with the information and the knowledge that we have on each single drug. And then, of course, having more options, it makes the market more difficult also for the patient. So the patient has started to having a saying in this. So the patient preference is indeed entering the picture of the decision. And as mentioned and anticipated, here I've been co-author in the AHA ESMO guidelines, and here we really see what I just meant, what I just said. So the first level of stratification is really the genetic assessment of our patients, mutated or unmutated immunoglobulin genes, p53 mutations or deletions. So we have to test for FISH and the sequencing of the gene, so 2 different tests. And then afterwards, we have to take into consideration age and fitness of the patient. And then we have this plethora of treatment, combination of treatment, as we say, as we see in a few minutes, that really will make somehow the decision of how to treat the patient difficult. So what we learn, so we start from the basic, I would say. So what we learn and confirm, and we presented the data at EHA in June, is that BTK inhibition is a main pillar, and I would say a crucial pillar of the treatment of patients with chronic lymphocytic leukemia. And here indeed we showed the follow-up of 7 years, where elderly patients were either treated with ibrutinib or chlorambucil. We are not interested in looking at the chlorambucil arm, but here the interesting data is that at 7 years, with the median PFS, progression-free survival, has not been yet reached. So 61% of the patients are still not progressing after 6.5 years. So that will prolong further the median PFS for this patient. So somehow, especially in the elderly, we are really reassured that we can control for a long time the disease. And this is true also for mutated and unmutated patients, as you can see here at the bottom left. So there is no more any difference in terms of prognostication or predictive power for the immunoglobulin when we use ibrutinib. And the last but not less interesting point is that if the patient remains on therapy, because this is, as you know, a continuous therapy for 7 years, then you can get a better response. So the drug is continuously working, deepening the quality of the response. So more than a third of the patient will achieve complete response, which, as we know, difficult to obtain. The same thing is true for patients with P53 aberration, which we knew that they are the most difficult patients to be treated. They should never be exposed to immunochemotherapy. And again, with continuous treatment, the continuous inhibition of the BTK pathway, then we obtain results that are similar, if not identical, to all the remaining patients. So on the left, we look at the pooled analysis of 4 different studies, 4 years of follow-up. Only the patients with deletion 17p and or p53 mutation have been considered. 79%, so 4 out of 5 patients are still progression-free after 4 years. And even in this particular subgroup of patients, we have long-term data from Adrian Wisner, the study, a phase 2 study at NIH. Patients in first line have been treated with mutation in p53 or deletion 17p, have been treated with ibrutinib, and again, 6 years, 61%. So very similar to what we have seen in the RESONATE-2 in the normal patient population. If we look at 4 years time point, 79%. So a completely different study, but the results are very similar. So really reassuring on the robustness and durability of this response. At ASH, we had the possibility, and Jennifer Voyak presented the update of the Alliance study. This is a different population, still elderly patient who can be treated with bendamustine plus rituximab, which was the standard arm, so a little bit fitter than the patient in the RESONATE-2 study. Comparing again to ibrutinib plus minus rituximab, we already know that the addition of rituximab does not really change anything in terms of progression-free survival. But again, with a longer follow-up, we are talking now about 55 months, so we are well beyond 4 years of follow-up. The advantage with the benefit with the ibrutinib-based treatment is really dramatic compared to bendamustine plus rituximab, first-line elderly fit patients. And the same thing is true for patients with p53 aberration that, of course, should never be exposed to immunochemotherapy. If you look at the patients with unmutated immunoglobulin genes, you see a dramatic benefit when using ibrutinib-based treatment. With patients with mutated immunoglobulin genes, there the advantage is much less relevant as we expect, but we know also that mutated patients are those who are less prone to receive treatment. Similar story if we even look at the young fit patient. Again, another study presented at ASH. Peter Hillman presented the FLAIR study, ibrutinib plus rituximab again versus FCR, fludarabine, cyclophosphamide, and rituximab. So we are talking about young fit patient who can tolerate FCR. And the PFS, again, it's in favor of ibrutinib, not yet reached with ibrutinib, is 66.5% for FCR when we look at the follow-up of, again, well beyond 4 years. We know that with FCR we obtain more complete responses, we get more undetectable MRD than with ibrutinib, but that really does not translate into the disadvantage, rather the opposite. So even if we don't reach complete responses, even if we don't reach undetectable MRD, the continuous pressure on the clone will translate into a long-term benefit. In the FLAIR study, the same information about immunoglobulin gene status is evident. So patients with unmutated immunoglobulin genes have a great benefit when they are treated with ibrutinib, even compared to FCR, which is the most potent immunochemotherapy. And this advantage disappears when we look at the mutated patient, where we know that both options can be good. And of course, here we have to discuss with the patient, and here the patient preference comes into the play. We have to discuss about fixed duration, 6 months with chemotherapy, continuous treatment with ibrutinib. But on the other side, as we see here, the patient treated with FCR may have long-term disadvantages like acute leukemias, MDS, or risk of infection that can last for up to 2 years after FCR. Of course, with ibrutinib, we know that we have a number of adverse events, because even if it is better tolerated and all the novel therapies are really an advancement in terms of tolerability compared to immunochemotherapy, but still they have their adverse events, which are mainly on the cardiac side for ibrutinib. But I just want also to draw your attention on the fact that we are typically talking about a population that is made of elderly individuals, and in particular with other comorbidities. So this is interesting when we look at the CLL-12 study, a study by the German CLL study group, where ibrutinib was compared to a placebo in a population who did not need the treatment, but it was treated in a preemptive way. And what we saw with a lot of interest is that if you look at adverse events, exactly the same percentage of patients complain about an adverse event in the ibrutinib and placebo arm. So even in the placebo arm, patients were having adverse events. And so really, we have to remember that the population that we are managing is indeed made of elderly, comorbid patients, so they might have many other issues that are not to be referred to the drug itself. So we have always to remember that most of the time it's easy to say it's because of the drug, discontinue the drug, and then the adverse event doesn't go away. On the other side, the major adverse event we know with ibrutinib is bleeding, but it's minor. Vast majority of cases it's minor bleeding. It really doesn't affect the quality of life of the patient, and it tends to disappear and fade away with time. Major hemorrhage may exist, and this is a problem with all the BTK inhibitors, even the second generation BTK inhibitors, and it's in a fairly rare population of patients, and only in 1% of the cases is really leading to discontinue. It's a cause, it's a reason to discontinue ibrutinib. In other cases, even if they had major hemorrhage, you might stop it for a bit, and then you can reintroduce it. The other issue that we all know is atrial fibrillation. I think that what we learned in the past 5, 6, 7 years is that really you have to start a tight relationship with a cardio-oncologist, which is really helpful because it will really reassure you on the fact that atrial fibrillation is not a major clinical issue. Of course, you have to treat the patient, you have to manage the patient accordingly, but you can start also anticoagulation therapy if it is needed. Not every patient needs it. That's something I learned from my cardio-oncologist. And the other issue relevant is that this higher risk is particularly high in the first 6 months, where you have indeed to keep an eye on the appearance of atrial fibrillation. Then later on, the risk is really decreasing a lot. And it will remain there, but also because, again, the patients are getting old, so it is, I would say, physiological or associated to aging, the fact that they could develop atrial fibrillation. So having said that, as I said, ibrutinib, the continuous treatment with BTK inhibitors is really a main and crucial pillar of the treatment of patients with chronic lymphocytic leukemia, and in many instances remains the best option we have. So I'm thinking about particularly elderly patients, where you can give your 3 pills a day, and you don't need to follow the patient closely. They can come back after 2 or 3 months for the visit, and we know, we inform the patient up front of what can happen in case they feel they have atrial fibrillation. They have to be referred to the hospital. And all the other cases, they can stay away. They don't need to be hospitalized. They don't need to do infusions. They don't need really inpatient care. In the elderly, as I said, it's probably the easiest option we have. Of course, when we talk about younger patients, the fixed duration treatment is an attractive option. So, of course, you don't want to bind the young patient in the 50s to a lifelong therapy. Even if, as I always say to my patients, if the drug will work for all your life, I mean, you should consider yourself very lucky, because it means that with one drug you can control it forever. But the fixed duration is, of course, a goal that we all want to obtain now that we have good drugs and we know that they work very well. We want to define a limited amount of drug that is sufficient to keep control of the disease. And that's why a number of studies developed the idea of the fixed duration treatment. And of course, thinking about the fixed duration treatment, the best partner with ibrutinib is the BCL2 inhibitors, in particular venetoclax, that is the only one at the moment approved. And that makes sense for the simple reason that ibrutinib is, as we know, very good in stopping the proliferation of the cells and mobilizing the cells from the tissue, the lymph node, the bone marrow, where they are really making damages, and they are the reason of anemia, thrombocytopenia, and large lymph nodes. Then they are mobilized into the peripheral blood, where the cells become much more prone to die, even alone, but in particular if exposed, of course, to a pro-apoptotic agent like venetoclax. So that will help somehow synergistically to eliminate both the proliferating cells in tissues and the resting cells that are mobilized into the peripheral blood. And that has been translated into a number of studies. Here I show you the Captivate study that I presented at ASH a couple of months ago, where a patient with chronic lymphocytic leukemia at the time of first treatment had been treated with 3 cycles of ibrutinib as a lead-in, so to debulk the patient, and then 12 cycles of 12 months of ibrutinib plus venetoclax. The study has 2 different cohorts, which are not randomized to each other. So one is the Mrd cohort, where patients at the end of the 12 cycles were tested for the Mrd levels, and those and were randomized based on those levels. So those with undetectable MRD have been randomized to discontinue the treatment, so placebo, or continue ibrutinib, which we can consider somehow a standard treatment. On the other side, those who did not achieve undetectable MRD, they were randomized to continue a therapy, either single monotherapy, ibrutinib, or the combination of both drugs, ibrutinib plus venetoclax. After seeing these results, we started another cohort, so-called fixed duration cohort, exactly the same treatment, but every patient stopped at the end of the treatment because we had some hints that the potency, the power of this combination was really dramatic in every patient, regardless maybe of the MRD level. Anyhow, here these are the results in the MRD cohort. So the first cohort, at the end of the 12 cycles, roughly 3/4 of the patients obtained undetectable MRD in the peripheral blood. It's very similar in the bone marrow. I just want to show you that this was all-comer study, so every patient with CLL could be enrolled. And though, I mean, roughly 1 out of 5 patients had a p53 abnormality, and 60%, so almost 2/3 of the patients had unmutated immunoglobulin genes, another 20 with complex karyotype. So the population is really mirroring and resembling what we see in first line in our office, and probably even a little bit more than that. So with a very 20% of patients with the p53 abnormality, which is very high, typically it's between 5 to 15%. So really suggesting that there was a lot of hope in this combination, and therefore a lot of high-risk patients have been enrolled in this study. And the data and the results are very interesting. These are the one I presented at ASH this year, or last year, 2021. So this was the updated analysis of 2-year disease-free survival. Disease-free survival is a little bit different than progression-free survival, because disease-free survival, it means that the patient is free of disease progression, of death, but also of MRD progression. As you can see here, there has been no event in the last year. So since the 1-year disease-free survival data that we presented in 2020, in 2021, 2 years disease-free survival remain exactly identical. And we are in both arms, more than 95% with 2 years after end of treatment had no event. The interesting point is that there is no significant difference between the two. So we can say that in a patient with undetectable MRD, we can safely discontinue this therapy, and at least with 2 years of follow-up, we can have the same result as continuing ibrutinib forever. Then we have also the patients who did not achieve undetectable MRD, and we looked at the PFS. In this case, traditional PFS, progression-free survival, we have 3 years from the start of the treatment, and as you can see here, again, also in terms of progression-free survival, 3 years, no differences between ibrutinib and placebo in the patient who achieved undetectable MRD, but also if we look at those who did not achieve undetectable MRD and they continued ibrutinib or ibrutinib plus venetoclax, again, a very high number, more than 95%. So the overwhelming majority of patients have 2-3 years that is free of any event with 12 months of treatment. And the interesting point I want to make here is that probably we talked about fixed duration, so 1 year equal for everyone. Maybe this is not going to be the case in the future, because if we look at the patients who did not achieve undetectable MRD and they continue treatment, those who received ibrutinib plus venetoclax, they were able to increase the number and the frequency of undetectable MRD. So somehow suggesting that maybe we should really use undetectable MRD as a way to achieve deeper responses in those patients who do not achieve undetectable MRD in the first year. Then we can add an extra year and we can really increase the number of these patients. And interesting enough also is that all these results, very interesting, I think, definitely very new results can be obtained with very little toxicity in addition. And indeed, only diarrhea is the only adverse event that is higher than expected with a single drug, either ibrutinib or venetoclax, that are both can be responsible of mild diarrhea. All the others are exactly in the range that we expect for the single for the monotherapy, for example, like neutropenia. And the interesting point I also want to make is that, for example, if you look at arthralgia, this is the placebo arm, and these are the treated patient arm, and you can see that the numbers are very similar, if not identical. Again, we have to remember that patients may have arthralgia for any reason because they are getting old, so it's not always because of the drug. Here I show you the SD cohort, fixed duration cohort, that and the paper has been, we presented at ASCO, but the paper has been accepted exactly today. So I just received the email, and in blood. And again, in the fixed duration, everyone stopped the treatment after the 12 months. Complete responses more than 54%. We don't really care about that because we know that undetectable MRD are much more frequent. Again, 3/4 in the peripheral blood, maybe here 2/3 in the bone marrow. We don't really know the reason why, because the treatment has been exactly the same. But the point here that we understood is that all patients, and this is a 2-year progression-free survival, all patients, regardless being having achieved undetectable MRD or not, they are still there, more than 95%, 96%, the one without deletion 17p, are still not progressing. So somehow we understood from this cohort that it's true that with following MRD, we can really personalize the treatment, but probably we don't need it. Because all patients, even those with the detectable MRD, after 2 years, they are still not progressing, and they are exactly on the same curve. The other point is, of course, as you would ask, and we are all asking and waiting for longer follow-up, is what happens in those few patients who progress. And here I just show you in a table all patients who progressed after fixed duration. So those who were in the MRD cohort and entered the placebo arm, who had to discontinue the treatment, or those who were in the fixed duration cohort where everybody stopped. So we are talking about 12 patients for which we have data on 9 patients, so really very few. But still, this patient progressed after quite a long time. So meaning one was almost 1.5 years, but all the others were more than 2 years after stopping treatment. So this is, I think, a reasonable time. 1 year of treatment, 2 years or even more free of disease, and then you need again treatment, which is fine. I mean, you are really giving a treatment holiday. Everybody responded with ibrutinib, as you would expect, because 1 year of treatment is not gonna give any resistance to the drug. And if we look at the genetic features, there is not really a story here. So some had division 17p, some had complex serotype, some had unmutated immunoglobulin genes, but half of them had mutated immunoglobulin genes. So it's probably we need more research to get to know predictive factor that can help us to decide, to know upfront who will probably progress. So I move now, I'm going to close my talk with the GLOW study. Again, the update is being presented at ASH 2021, where the same combination, ibrutinib plus venetoclax, has been compared to chlorambucil plus obinutuzumab. So we are talking about elderly comorbid patients, and this is a registrational study, it's a phase 3 study. And again, no surprise, the combination I plus V is much better than chlorambucil plus obinutuzumab. We had probably no doubts, but this was requested by FDA for approval. And again, the same story, the better PFS is also due to, very likely, to a higher frequency of undetectable MRD, and in particular, even very deep undetectable MRD, so below the level of 10 to the minus 5, which is much lower than the 10 to the minus 4, which is the standard undetectable MRD. But the point I want to make here, following also what we saw in the Captivate study, is that, of course, the patients who achieve undetectable MRD with ibrutinib plus venetoclax tend to remain much longer in the undetectable MRD status compared to chlorambucil plus obinutuzumab. We know that's expected. But interesting point is that even the patients who did not achieve undetectable MRD, they do not really progress. So they do not really, the levels are not really moving and progressing with time. And again, given the impression that we had also in the Captivate, somehow the patient treated with this combination, regardless the level, they are probably, because of modification of the natural history, they always, sorry, apologies. They achieve a benefit regardless achieving the fact that they achieve undetectable MRD. And therefore, you can see it also here, that patients with or without undetectable MRD treated with the combination have a very similar and very prolonged progression-free survival, much better even the patients who achieve undetectable MRD with immunochemotherapy. So this is something that we have to keep in mind, for which we are a little bit struggling because it's counterintuitive, but that's why we were also keen on doing the fixed duration cohort in the Captivate study. With this, I conclude, and I thank you for your attention. And as I said, the future of treatment CLL is becoming maybe more complicated, more interesting, definitely, and new options like the combination is probably going to be very helpful for many, many patients. Thank you very much for your attention.